we have Professor Dr. Francesco also with us.
Yes.
Yes.
I'm here.
And we don't have the video. It's fine. We have just the audio right now. Yeah. Okay. Not a problem. Yes. So if we start from the first presentation with Dr. Francesco. So you have mentioned that the Prevent4Work questionnaire was developed to have an overall assessment to identify risk factors and guide the education. Can you tell us a little bit about where are we in the process for the Prevent4Work questionnaire and what are the future perspectives for it?
Yes, of course. The thing is that up to now we don't have enough. I didn't have enough time for during the presentation and not enough data to support or explain the future approach for by using this kind of questionnaire. The thing is that up to now we assuming to collect information regarding the stress, the mental stressor, the physical stressor, job satisfaction and kinesiophobia and catastrophizing behavior to direct the educational content. The thing is that up to now we are trying to integrate in the APP and try to match the results with the common clinical practice. The thing is that the future step will be to assess in a different point of follow-up to assess exactly the development of this clinical condition. This is something a little bit different. I mean, we know by investigating the behavior of this kind of questionnaire and matching it with the Oswestry Disability Index and the Fear Avoidance Belief Questionnaire, we know that something could be potentially rise up. The thing is that up to now we need time to understand if this could really be a useful tool in terms of diagnostic capabilities. That is something a little bit different up to now.
Thank you, Francesco.
Yeah, welcome.
Yeah, and being a doctor, how do you think the acceptance of that will be in the field? And can you tell us how you think that this questionnaire could be used by the doctor as well? Yeah.
Yes, thank you. The thing is that each time that we propose a kind of treatment, a kind of a new tool, we have to exactly put an overview of the potential of this instrument. The thing is that up to now, if we are enough, we put enough effort in this kind of investigation, and I say this also for the researchers. The thing is that this kind of questionnaire will actually be growing up this common use, because the thing is that for the larger part of surgeon where I work with, this kind of approach is considered a kind of a dark side of medicine. But up to now we have to know, and mostly we are a group of a spine surgeon. But the thing is that up to now we have to know, we have to realize, we have to figure out that the larger part of our patient do not require a surgical approach or a specific surgical treatment for an area or injection and stuff like that, but required firstly an overall assessment. So it's a kind of, for us, it's a kind of an effort to change the common view that we use, because we grow up with a biomedical approach for this kind of problem. So it's a kind of probably the future will say the truth.
Yeah, the participants earlier today have mentioned some dinosaurs and ancient information and history. And they have also talked about that we are contributing to changing the world. That's very simple task to be done. And that's very nice to have different perspectives in seeing the problem, so we can also help to translate what we are finding to the different publics within the professional health and everybody else. I can give you the opportunity to comment on that if you want, Thor, but I will also connect the question to you We would like to know a little bit more about in the scoping review. If you can let us know a little bit about the content of the education.
Oh yeah. So in general, or so the education that was provided in the studies we included?
Yes.
Yeah, it was quite varied. And in many of the cases, they tried to, as I said in my talk, it was very often used as the control arm, especially in the randomized trials. But in general, the messaging of the educational material was sort of positively loaded. So they tried to reduce harm, reduce risk in some of the material, for example, in the Rantanen studies. But in other studies, it was more biomedically grounded, where it was on, this is the way you're supposed to sit, this is the way you're supposed to lift. And then we had the whole spectrum in between. So it was, a lot of it was is pretty old school, and a lot of it was quite contemporary, especially in the studies that were conducted, and with the ones we included that were conducted in after 2010, if I remember it correctly.
So if you think about it, like there's another question that matches this one, as a health professional and a researcher. So what type of those education would you use when you refer to manage an injured worker?
Yeah, I think here we have a huge responsibility, and of course I would be massively biased when I would be sitting in my clinic, because I would of course recommend using the Prevent4Work app, because I think it's based on the latest or the contemporary evidence, and it not only does it spoon feed you with information, but it also allows you to interact, to test knowledge retention, and you can revisit it as often as you want. But the question is also, and here I think it becomes a bit tricky for us as healthcare professionals or providers, when is it enough to provide them with education in the clinic, and when do we feel that it's necessary that we add on to that something that is available online or in a format of a pamphlet or a booklet? I think it might have quite an empowering effect if the patient can see that what I'm stating or claiming in the clinic is not something that only I'm saying, but this is also something that is being promoted elsewhere. So I think for that, in those cases, that would be quite relevant. But if we were talking about, let's say, a worker who sprained his back after lifting a box and was already in recovery, you would sort of try to make an educated guess on how important is it to give them the additional work of going home and watching the videos. As a sort of if you were to employ an approach where you just wanted to be sure, you would of course do that. But as I said, it's the clinician and the patient in each case you would have to evaluate when it would be appropriate. Yeah. I think that's a fluffy answer, and I admit that, but this is also the reality. So there's no black and white in it.
No, definitely not black and white, and we accept that you must discuss that, include different ways to approach a very complicated, complex issue. Yeah. We heard from Dr. Francesco a little bit about what could be some barriers within the medicine field to use the questionnaire, for example. But we can also use that, if you could, Dr. Francesco, and I think it's for both of you, there's one, can we foresee some problems using educational material, thinking about the health professions that will deliver that, some barriers that could be on the way, and the facilitators maybe. I can let you start, Dr. Francesco.
The thing is that when we suggest, when we consider the knowledge, the educational, as a source of management or treatment of this kind of problem, we actually may have some barrier. I mean, in this kind of condition, which is exactly important, it's the quality of the information that we have to we have to suggest to our subject. And this is the reason why Dr. Palsson actually suggested to use our platform, or the platform or Prevent4Work, because it's actually developed on high quality materials. But in my personal opinion, one of the barriers that I've seen by working with other colleagues, by working with health professionals, is that we growing up as a professional by looking for the pain generator, by looking for the discogenic pain, or facet joint pain, or spondylolisthesis, and so on. The thing is that in the larger part of this kind of patient, where we are lucky to say that there's nothing, we usually let follow this kind of patient in a huge category that simply has nothing. We actually really think that has nothing. The thing is that up to now and actually represented the larger part of this kind of patient. The thing is that up to now we have to reconsider this larger population, this larger environment of worker and subject, and reconsider the message that we commonly send to this kind of subject. I work as a physician also in the south of Italy, and one of common the typical subject that comes to my office, it's a woman more than 60 years old that usually says that she feels pain everywhere, from the bottom of the head up to the foot. The thing is that in this kind of patient, we have to understand that probably if we didn't find a specific pain generator, probably we have to understand that we have to manage something more. And by providing and sending them the information that they are not disrupting their own back or the shoulder and so on, and try to understand that we need the subject need an overall reconsideration of a clinical condition. Up to you.
Want to complement Thorvaldur with something?
Yeah, I fully agree with what Francesco was saying, and I just want to state again that us healthcare professionals, we have a massive responsibility, because often we are the people or the professions that patients seek help from when they are in pain. And here we have to be able to provide, or we can call it education or advice or information, that is scientifically grounded. Because we know, for example, from a lot of so Jenny Setchell did a study published in 2017. Ben Darlow's work does also reflect this, where normal people out on the street are asked, where does back pain come from? Where does pain come from? And in the majority of cases, so in Jenny Setchell's study, it was around 90% of participants with back pain. They considered to have an underlying biomedical or the majority considered to have an underlying biomedical explanation. And in 90% of the cases, this information was from a healthcare provider. So it's not something that they've picked up in social media or just found on Google. This is something that a person with a medical degree or a physio degree or a chiropractor or whatever degree has informed them of. And this is probably one of the things that we wanted to address in the Prevent for Work Consortium. So now we try to develop educational material aimed at workers, but we also have a section in there aimed at healthcare providers. So we want also healthcare providers to be able to access the best available evidence on various topics within musculoskeletal pain in relation to occupation here, but this applies also for non-occupational settings. Because we have to acknowledge also that in a busy clinical day in the hospital or in the clinic, we can't really go and read the latest systematic review of the literature on how to manage things. So we sort of, very often we're left to do what we normally do or what we think is best, which is not always supported by evidence. So this was also considered as help for these for clinicians.
That's important to acknowledge.
Yeah.
The difficulties to apply this knowledge in the practice. We have a question for Francesco. Now, if we think about the biopsychosocial model, how does that can be integrated on your practice, for example? Can you say a little bit about that? As an orthopedic surgeon.
Yes, as an orthopedic surgeon, it's quite difficult to try to apply the biopsychosocial approach in my clinical practice. But the thing is that up to now, I think that we have to build an environment of colleagues, of workers that working on same kind of subject, and we actually assume to have some other colleagues that will help. The thing is that up to now, if I have a patient that presented a behavior of catastrophizing or fear avoidance pattern, up to now I used to talk with my physical therapist and say, pay attention for this kind of movement. The subject needs to be encouraged to perform this kind of movement, needs to know how to perform this kind of job or this kind of work. For some other condition, we actually refer to clinician, to other clinician. For example, for pattern of catastrophizing, we usually to refer to other clinicians that will help us to have a 30-60 management. As orthopedic surgeon, my aim in my office is to try to detect and to identify any kind of shade of this kind of behavior patterns and try to address this to other colleagues. But the thing is that up to now, for me, most important is to spread this kind of information, to spread that this approach actually exists and actually can improve the quality of life of your patients. So you have to understand this, and you have to address even to other professionals, but you have to know that is a real condition that can help you.
Definitely, yes, thank you. Now, this one, I think it would be interesting for both of the panelists to try to answer and cover that. I think it's like we just talked about this biopsychosocial model. We are talking about including stressors. There can be psychological, physical stressors, and so on. But when we think about that, one of the recommendations is to the best situation to continue to work and avoid sick leave. So I will read the question. So if you think about the recommendation to try to get the person back to work soon, what happens in cases where the worker has personal problems at work? So if you take the social part of it, for example, bad relationships with bosses and colleagues, and we can further think about like the different regulations in the different countries and so on. Can you, maybe Thorvaldur can start saying something
happy
about
to.
that?
I think it's a very valid point, and because if we think about the biopsychosocial model, this would be highly related both to the social part, but also to the psycho part, because being harassed in the workplace or not being able to get along with colleagues, etc., also affects people psychologically. But here I think we have also a role, but we also have to consider that we also have limitations when it comes to this, because there are factors maybe in the patient presentations that we can modify, and then there are factors that we cannot modify. We cannot intervene in terms of moving that person to another department at the office or do something along those lines. But nevertheless, I think it's very important that we are able to address this and make it, maybe get it out up on the surface, that this is an integrated part of the problem. So that the patient is able to take an educated decision on what's best for myself. Because if we consider this to be a worker with back pain who is also having a hard time at job in a stressful environment, or a boss that is being a nuisance, we have to consider that the back pain is something that we can help the patient with, and in some cases get rid of. But if it's the psychological environment at the job which is a barrier, this needs to be addressed, and then it needs to be managed either by the patient himself, but this would be, and in collaboration with the employer, of course, and in Denmark you would have the municipality very often involved in this to try to find a mutual solution to the problem. But I think the important point here is that we consider that there are only so many things we can change as clinicians, but the best thing we can do here is get it up on the surface and make it clear that this might be a part of the problem.
Yes, thank you, Thorvaldur. Francesco, maybe you want to add something about the Italian context, or maybe as a doctor?
As the Italian the context, first of all, I'm actually totally agree with the Professor Thorvaldur. The thing is that when we talking only about education, the same kind of education it's mostly easy to provide in different fields, in different national contexts. When we talking about in terms of barriers, like to ask to the patient to come back to their own job, it's something little bit difficult. It's a step forward, and probably not all countries are well structured as the Northern Europe. The North Europe. The thing is that up to now, when I try to address and I'm phasing out to a condition where I feel that it's a barrier, I try to explain better the condition to the subject, to try to see if with some figures in a working environment will be able to remove this kind of barrier. One common example is try to come back to worker to the job by using a part-time approach, and I feel, and now actually I am looking for this kind of approach, because each time that I have a worker, for example, that can come back in a part-time approach, in a part-time approach, actually I feel that the recovery, even after surgery, it's faster, it's considered faster. So probably it's we have to put on surface this condition first of all, and we have to educate our workers to ask and for looking for this kind of barrier removal. So it's a long way, but the first step is here.
It takes time to change the world, for sure. Thorvaldur, I have a question for you here. The 27th of October will be the World Day of Occupational Therapy. And I have a question that's starting to, would like to hear from us, like from you, Thorvaldur, especially. if we have considered to include occupational therapists in the project, because in some countries, they are responsible for making risk analysis and are specifically working in the work context related to.
Yeah, very good point and highly relevant. And unfortunately, we did not have an occupational therapist on the team that worked on the scoping review, but this would have been highly valuable. When it comes to the studies we included in the scoping review, we did not really differentiate between interventions provided by occupational therapists or physios or doctors or nurses, as long as education was being provided by a healthcare professional, it was included. And in many of the studies, these were defined as occupational health and safety workers without specifying necessarily the background. But a highly relevant point, and definitely an area where occupational therapists are very qualified.
Yes, it has been a very interesting discussion, but we ran out of time right now. We need to stop. Thank you both for your presentations and for participating with your input on this discussion.